Barry is a member of the Métis community of Saint Laurent, Manitoba, and a descendant of Duck Bay and Lake Manitoba First Nations. He's a family physician specializing in Indigenous health and Northern practice, focused on the healing needs of First Nation and Métis communities. Barry's research is centered on chronic diseases, transgenerational trauma, the impacts of colonization on Indigenous communities, and international Indigenous health. He was the Director of Student Support and Education for the Center for Aboriginal Health Education and Indigenous Health, Curriculum Lead for the University of Manitoba, and he's currently the Chief Executive Officer of Keewatinohk, Inniniw, Minoayawin. Sorry, I butchered that pronunciation. Where he focuses on health transformation and innovation to address inequities in Northern First Nations. So I'll hand it over now to Barry, and I'll bring up a presentation.
Thank you. Sorry about that, guys. I was waiting online, but our paths didn't cross, so I sent a message to Karen and said, what's going on? And so now I'm here. Just gonna put up a PowerPoint. I see my buddy Joe Crawford there. Call me, we got to get together, Joe. All right.
All right, all good?
It's all good. Shall I start?
Good to go.
Okay, I'll time it for about 40 minutes or so. So welcome everybody, and thank you for inviting me to give a few words about some of the work we're doing in Northern Manitoba. Turtle Island Man, Dishnika, St. Laurent Dunji, Makwadu Dam. The Christian name that was given to me at my birth, I'm the 8th of 9 children, to a First Nation and Métis woman and a First Nation and Métis man. And on my birth certificate, as part of the initiation into colonial violence that ruptures identity of Indigenous people, they named my mother, whose last name, whose maiden name was Campbell. They called her Irish. And then my father's name was Lavallee, and they called him French. But he was as dark as night. And both my parents, their first languages were Ojibwe, Soto, and then Michif, and then French and English. And so part of the demystifying colonial violence is really understanding even one's own roots and origins, and kind of the the colonial tactic to take away identity and language. I have like quite a few degrees compared to my mom and dad, who didn't finish much in school, but they spoke like 4 languages, 5 languages. I have an MD and a master's, and I started a PhD, but left it, and I could barely speak English. So really, colonial education doesn't actually advance anything too much. So I stand corrected on that. But about 2-3 years ago, some leaders from Northern Manitoba came to meet me, and we had coffee, and they wanted me to actually work on the development of something called Keewatinohk Inniniw Minoayawin, which was a budding concept that came out of MKO resolution by chiefs, as well as years and years of community engagement. So far, like 25 years or so, really that articulated that Indigenous peoples and First Nations people in specific wanted doctors and nurses and systems to reflect their own values and concerns, and to have their own people deliver care, and to transform care, and to take over systems that wholly fail to meet the health and wellness needs of First Nations people, and further systems that, as part of the colonial structure and objectives, is to kill the Indian solely. And that concept, I've been working with that on that concept to understand what that relationship is between primarily white settlers, but now even non-white settlers, and the high rates of death, destruction and harm that come with going to see a doctor or going to the emergency room somewhere in Manitoba, or being admitted to have your baby and have your baby stolen from you. You know, so it's really important to understand the origin and the roots of why Kim is important. And for those of you who mostly, I'm sure, well-read and understand that the colonial project is really about killing the Indian to near death and then bringing he or she back and then killing the Indian near death again. And Shireen Razak, and she's at UCLA now, says in her literature that the settler is compelled to go to the grave of the dead Indian. And you see it historically in lots of literature. And they're compelled to go there and to kick at the grave site and to kick at the dirt, because it's a dual nature of being a settler on stolen, blood-stained lands called Canada. Because you benefit by our death and you benefit by our suffering. And so that relationship really is the function of settler Canada. So much so that settlers will be compelled to try and understand their own humanity in the context of the obvious genocide that goes on in 2022. And that's been going on for a long time. And to try and define it in the context of you going home to a warm bed tonight and you having food and you having possibility and you 3 generations from now seeing your grandchildren going to medical school at the University of Manitoba, versus for Indigenous people, we're just trying to survive in many ways. We don't see ourselves going to medical school. We don't see ourselves becoming PhDs. And so that's really the dual nature of what happens and the consequences. But importantly, and I won't spend too much time on that because I see some of my friends are in the crowd there too, that why is that understanding important for the development of a health system to address the care and concerns of First Nations people? I want to give you an example. There's $115 million that the Manitoba government has allocated for intermediate, is what their definition is, transformation for the healthcare system in the north via the province. And the feds, Kim will eventually assume control over services by the federal office here in Manitoba. So their office goes down, our office goes up. But one of the things we stated in the preliminary discussions about the development of Kim was that Indigenous specific racism is a through line for any engagement with either the province of Manitoba or the federal government. And if Indigenous specific racism is not a through line, then I walk away and we walk away. Because if you put Northern Manitoba, you know, 5 surgeons and you have the most sophisticated systems up in Northern Manitoba, you know, you make the emergency double the size, you add 20, you know, physicians, it still will not address healthcare for First Nations, nor importantly, will it actually embrace something called traditional healing practices, nor will it look at wellness. Why? Because access to care by First Nations people who are identified by settlers, who are the gatekeepers to health in Manitoba and across Canada and other countries, if you identify an Indian, it's really important that you bring the stereotypes that are part of your identity formation in these colonial lands. And I'm talking about the work that we've done with BC, Cheryl Ward, Laurie Harding. We've been working together for a long time. And we invested a great deal of time in understanding Indigenous specific racism and how it's manifested. So if you go to an emergency room at the Health Science Center and maybe you have some scars and maybe you've had a couple of beers, you know, you will enter only in stereotype. That's really important. And white people and maybe brown people, I don't know, I'm not an expert there, but white people can have a cognitive understanding, but never a deeper emotive appreciation of what that kind of oppression looks like. I'm not going to speak about oppression of women, people who are gay, transing, or that kind of stuff, but you'll see that intersectionality is really important, okay? So if you are a lesbian, dark-skinned First Nations woman who is in a wheelchair and lives on social assistance, death can be near you long time, really quickly. And the system in its anemic response to, as an example, the missing and murdered Indigenous women and girls will only think that somehow you created the opportunity for death yourself. But let me pull back a minute. So when the leaders came to me and they said, oh, do some population-based stuff and innovations around changing health for First Nations, that's really why I was hired. And then once Keewatinohk and Inniniw Minoayawin became incorporated, or before then, they asked me to assume the CEO position. I'm not trained for that. I'm a family doctor and a scientist, but I assume that responsibility with a lot of pride and support by community members as well as chief and councils and our elders. So that Kim, in fact, is really looking at innovations in healthcare. It really and primarily wants to address Indigenous specific racism as it's manifested at multiple levels in the healthcare system, all the way from settlers who only think about Indigenous people in the form of stereotypes. Drunken Indian, women are not good mothers, children have snotty noses when they come to emerge because mothers don't care about them. On and on and on. They smoke, they drink, they're fat. So their health outcomes then in a deficit model of analysis are because you are who you are. That somehow being First Nations is inherently deficient in such a way that your mortality rates are a function of who you are. That is the opposite side of white supremacy in Canada and white supremacy in medicine and white supremacy in nursing, etc., etc., etc. But really, what ends up happening is that the colonial world creates the narrative and scenarios that you see today. You know, we have the highest rates of HIV in Manitoba, and this province is doing a shitty job in public health to address preventable diseases and STBBIs. We have a syphilis outbreak. We've had 3 kids die in the last trimester of in their mom. And we're just now investigating these particular cases to find out what happened in the healthcare system that these 3 women and families who were positive for syphilis and their babies died in utero. This isn't 1920 or 1910. This is 2021, 22, and 23. And yet the system inherently fails, not because it forgot, but because that's what it's meant to do. And people are not comfortable with that logic. The logic of settler Canada is to kill us almost to the point of not breathing, but to revive us. Because if there was one Indian left in Canada today, and if that Indian died, Canada becomes nothing but German, Nigerian, Chinese, on and on and on. So Canada, when you unfold the blanket of Indigenous identity mixed with Canadian identity, Canada no longer exists. Canada is but what you came here 100 years ago, 200 years ago, a day ago. You bring your language and we embrace it. You bring your oppression and we use our monies to make sure you're no longer oppressed. While at the same time, today, I was on a meeting with a community that is having, we believe, 30% of that community are hooked on crystal meth. Of 1,500 people times 30. Look at the math. But the system, the federal system, the provincial system, turn their head and pretend to give anemic responses because the systems are part of the colonial job of killing the Indian and keeping them suppressed so that whiteness, white supremacy gets to replicate itself continuously on stolen, blood-stained lands. And we had only at this meeting Indigenous organizations, because we're scientists too, right? But we have no resources. So we got to figure out a way. We know actually how to deal with harm reduction. We're quite good at that. But this government here in Manitoba is a white conservative government that doesn't like women, gay people, dark-skinned people, and certainly does not like the original people of the land, First Nations, Métis. They do not. And in my experience in the last 2-3 years, that is seriously evident. So what do? We don't ask for permission. That's what we do. We do not ask for permission because you have to see that the resources that come from these lands is rent. You owe us rent. Okay, you owe us rent. We do not beg for resources. We demand resources to attend to the 150 years of colonial violence that manifests itself today in health behaviors that you will term, you will only manifest it in your mind as deficit, meaning you embrace the concept of the dead and dying Indian, and you provide us with palliation because you believe, and you, I say plurally in terms of Canada, believe we're on the path to death only. And so it's more important to palliate us rather than to look at the actual cause of poor health, murder, social isolation, and a whole slew of things that are well documented in all universities across Canada and across the world. We know what's going on. None of us are stupid. This is really a function of why Indigenous specific racism is the monetary thing that Canada moves about and utilizes. And they lie too, right? The colonial system lies. And they have a straight face. And generally, not picking on white people too much, it's a smiling white face that says, yes, that's really terrible that you've had another 4 children under 10 die in a fire in Thompson. That's really too bad. And I say that in such a way because, you know, Kim, we have a board of directors now. We have a lot of really great staff, and we have innovative thinkers. One of our board of directors, his grandchildren, died in that fire. And so what does that mean for us? It means that I don't have a leader to give me a hand, that we've got to help the family, try and find a way to bury those babies, to look at what is wellness afterwards, and how is it that we support that family. And well, you know, perhaps for those of you sitting in the seat and listening to me, you think, oh, that's crazy. I'm sorry, that is the 7th child who's burned in a fire through the pandemic. 3 in one, 4 in the other. These phenomena are not that, they're actually quite, they occur quite often. We had, you know, there are 2 things that have gone on in the last 2 years. When I was hired to look at population-based interventions, one of my areas of expertise is looking at chronic diseases and understanding how does diabetes, hypertension, chronic kidney disease, why are the rates so high in Indigenous people? Just on a quick side, we did a screening, disease location, and then treatment plan, a tripod like that, with 2,000 First Nations, majority of whom live in community, and then a smaller group who lived in the urban area of Winnipeg. And you know what we discovered? 2 things that my colleagues didn't want me to publish. Number 1, if the federal government controls your life, your rates of chronic kidney disease go up. If you live in a community that has road access to a provincial system, there's less, but you still have high rates of chronic kidney disease. If you live in Winnipeg, where there's supposed to be access to everything, you still have higher rates of chronic kidney disease than white people. And in fact, when we looked at the data from 5 to 80, and we looked at the rates of protein, sugar, and blood pressure, the rates are higher than white men with diabetes and hypertension in large-scale studies. What was that about? It's not about smoking, obesity, and not wanting to eat properly and eating chips and chocolate bars. That's all bullshit. What we discovered was, and we theorized, that the link between missing and murdered Indigenous women and girls and others in our community actually can change the genetic makeup or epigenetic status of a two-cell human. We believe that chronic diseases start at 2 cells, just after the sperm enters an egg. Why? The only logical reason for that was the acute and chronic stress of oppression, poverty that Indigenous women live under. That's the only way that we can rationalize. So that a baby who might develop chronic kidney disease already before he or she has left their mom already has kidney disease. And when that baby exits their mom to a loving mom and dad, they still must contend with a wholly violent society where if you're a dark-skinned Indian and you look like a Hollywood Indian, your life will be hell. You could get an MD, you could get a PhD, you could be the smartest person in the world, but the violence is irrelevant. So that the concept of social determinants of health is bullshit. You have to address racism. And by addressing racism, at least you can have access. You could go into a hospital instead of dying, like some of us have died in hospitals from neglect. You can actually enter a hospital with chest pain, have your chest pain checked out, and if you have heart disease, have a definitive treatment and exit. But if you enter any healthcare system here in Manitoba and across Canada, I would suggest you enter at your own risk, because the only way that people actually decide what's going to happen to you is how I feel as a settler at that one moment. Whether I hate the fact or I think that you're actually drug seeking, so I'm not going to do a CT scan of your belly, even though it's probably cancer. So that the stereotyping as a function of how Indigenous specific racism is manifested in the healthcare system is very, very real, and it is true. You know, I had one patient, well, he wasn't my patient, but I was contacted from Northern Manitoba with the docs. I have 2 First Nations doctors working with me at the office. And a young man, 42, had spent 3 years trying to get somebody to look at his foot because his foot was sore. And this is in Northern Manitoba, Northern Health Region. If the Audrey Gordon is in the room, Audrey, I told you about this. So he had a sore foot. He was a heavy duty machine operator, making about $2,000 a month, which is really was good for him. 3 years later, he's on social assistance and almost homeless. What happened in that 3-year time? So we interviewed him. Before I interviewed him, we actually ordered a CT scan. We told the Northern Regional Health Authority, get a CT scan of his foot. And lo and behold, the young man had osteomyelitis, an infection of the bone that nobody wanted to look at. And in fact, this young man had a psychotic episode after using drugs once, but they labeled him psychotic. So through that 2 years, you had psychiatrists trying to convince him to have the foot cut off. They took his rights away and they imprisoned him only because he wanted somebody to look at his foot. It was painful. And so he was tortured for 3 years by the healthcare system in Manitoba until one First Nations doctor said to the Thompson General Hospital, do a CT scan of his foot now. Lo and behold, he went to infectious disease in Winnipeg, had 6 weeks of IV therapy. The man is walking around today. And yes, he wants to sue the system. And yes, he should sue the system. Now, you know, I want you to understand that the emotion that I express during this time is a function of really being tired with all the stuff that's going on, and really kind of being tired of the anemic responses by both the federal and provincial systems, and the anemic responses by my colleagues, healthcare people. Very, very anemic responses. So what is this complicity about? The complicity really is about trying to kill us. And why is it necessary to kill the Indian on their land? Because to kill the Indian, and this is a unique feature of Indigenous specific racism. So it's not like Black racism, brown racism, all those kinds of things. Because in order to continually steal and rape our land, we have to die. You have to understand that. So I never do BIPOC work at all. Indeed, racism affects other people. That's not my business. My business is to understand the unique features of what Indigenous specific racism is and how it manifests in systems. After Joyce Echaquan was killed at Joliette, Quebec, we had some national engagements with the federal government. And I asked them for money to address Indigenous specific racism in Northern Regional Health. And they gave us about $4.7 million. And so we're developing systems to be able to dismantle that place, hold people accountable, and importantly, when people exit somewhere in the Northern Regional Health system, that you can ask them, how was that engagement? And if they smile and say, didn't go the way it is, but it's fine, I'm okay. That to me is the best evaluation, really, is when people exit, if they're alive, just kidding, and that they feel that they've actually been listened to. That's not very sophisticated population-based sciences or evaluation, but that would be excellent. I need to tell you, when we put Kim together, or the chiefs and the community people put this together, we got tons of cases that we had to investigate all over Manitoba, because people were just having poor outcomes. They're being treated poorly. They're being accosted and bullied. One of our elders from a community who never, and this is unimportant, but let me emphasize how stereotyping works. So this woman is a Christian woman. She's never smoked or used any alcohol in her 70-something years. And she was admitted to Grace because she's a diabetic and she had cellulitis on the left or right leg. And a brown doctor every day accosted this Cree elder and said, please admit that you're drinking. And that's why your leg is sore. And she says, no, I don't drink. And her daughter, who's a very important person in our community, made a complaint to Grace Hospital and made a complaint to the College of Physicians and Surgeons. I don't know what the outcome is, because we're working with the College of Physicians and Surgeons to articulate, operationalizing how Indigenous specific racism will become a complainable thing to the College for Physicians. But the woman who was accosted during her admission to Grace Hospital here in Winnipeg really wondered why a brown doctor would treat her that way. And that's very important you understand that. It's very, very important. We had looked at this evidence of coaching. And we published a chapter in White Benevolence that encourage you to buy it. That money goes to, where's it go? I don't know more. So we don't get any money from that. But it's a very, very sophisticated analysis of how White Benevolence works. But she wondered why a brown doctor would treat her that way, because she thought only white doctors did that. But she failed to understand, and it's nothing against her, that when the settler comes here, and even settlers who are not white, they will adapt and take up the way you have to manage Indians in a healthcare system. They'll adopt it gracefully and greatly and appreciate it, because they then become one of the colonizers, and they have the power and the structures to actually uphold their own needs on bloodied land. And so we didn't speak much to the elder about that, only to say that she was treated poorly and that really was not her fault. She was subsequently admitted and refused to have her daughter do anything. And this elder didn't speak, did whatever they wanted. And when she wasn't treated right, she did not want us going to the nurse or to the system or to whatever, because she feared she'd be treated really poorly. That is called damage. That is called fear for your life. And that is being powerless and really in the face of stereotyping. I guess I was supposed to ask you to move some slides along, so maybe we could do that, okay, Neil? Yep. Let's see. More. Continue. Again. 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 Okay. I'm not going to go through the governance. We have a governance system that is kind of a 3-level governance system, and we're just manifesting that now. Very difficult still with the impact of COVID or the pandemic in our communities, as well as with our leaders. We're having lots of illness. There are deaths occurring, but we're pushing through. So I'm not going to do kind of a really dry kind of thing. I want to tell you that diagnostics and other physician services, we've put updated x-rays in many of our communities. We've used technologies to try and increase capacity and opportunity for providers in our communities, like point of care testing, ultrasound. We use some of our monies to actually increase physician services, especially during the pandemic, when communities didn't want doctors and nurses coming in frequently, fearing that they would bring the COVID virus in. We do some work with Jordan's principle, which really is a function of trying to, and I'm sure all of you understand that, trying to take care of children with complex needs. It's, in my mind, not very successful, but I won't go into that analysis. We're looking at workforce development. So we did start a diagnostic support worker, and really it's with Red River College, and people can do an EKG, chest X-ray, and EKG, chest X-ray. Oh, I know that, Catherine, you're sitting out there. Well, they can do, thank you. Phlebotomy. But our intent really is to take over health services, not only just the operational things like in an office, but really to develop a workforce that can stay in community, that could be guided by chief and
Sorry, folks, looks like we lost Dr. Lavallee for a minute. Oh, there he is, he's back.
Can you hear me?
Yeah.
So did not 18 nurses, graduates of the University of Manitoba, did not pass an English proficiency test, okay? And so they were denied a license, but they were successful in graduating with a Bachelor of Nursing, done in English, trained in English, saw patients in English through the University of Manitoba, but couldn't pass an English proficiency test, which I understand from one of the senior nurses was only brought on because one nurse, like 20 years ago or whatever it was not providing good services in English. So they actually did a white supremacist type thing, and they said anybody requiring a license must pass this European-based English proficiency test. So we had 18 nurses who could not practice nursing during a time of extreme nursing shortage in northern Manitoba and across Manitoba, and are going to Ontario and Saskatchewan and practicing nursing there. And so we took this to the Minister Gordon through a UGME, and they presented it on the floor. And what was really telling to me about the development of the colonial system continuously was that on the floor, all the parties stood up 3 or 4 times with an ovation when they were talking about a kids group, like a 4-H or something like that. Everybody stood up. And they honored a foreign doctor, I believe it was. I couldn't understand too much because he had done great work around the world, and his family was sitting in the legislature, and they stood up. So UGME said to Minister Gordon, I want to tell you about the 18 First Nations nurses who are not working as RNs, some are working as LPNs because they couldn't pass an English proficiency test. Minister Gordon refused to stand up and look at us. All she said was, there's one immigrant nurse who couldn't get her license, and that's all she said. She refused to engage with the 18 First Nations nurses who passed a very, very important degree from the University of Manitoba and have a bachelor's of nursing. Refused to. And that to me is telling of the ongoing violence against Indigenous people, especially when we have no nurses. And these are 18 well-trained nurses who want to work. Can you imagine that, eh? But really, they mark the anti-racism on this particular side as research. It's not research, it's praxis, really. It's really around holding systems and providers accountable. And we're doing it in 4 areas, and I'm not going to go over there. But importantly, you have to understand that the federal government asked us to consider the health of women as part of that intersectionality to address Indigenous specific racism. So we are looking at developing a model of care using Indigenous birth helpers from community to interpartum care to aftercare to be able to facilitate ways to address not only adverse childhood experiences, but the health, healing, and wellness needs of mothers who are pregnant and their families. And so that is work is going underway. We really don't have a lot of support from the provincial government. We have minimal support from the federal government, really. But we're moving forward on this. And there are some people in the crowd we have there who actually have been working with us in this particular area. So we're quite proud of that work. The other thing I want to tell you just quickly, how much time do I have, Neil? 5 minutes?
About 4 minutes.
Okay, good. Importantly, you got to know that harm reduction, the lack of harm reduction services in Manitoba with its conservative government is killing Indians today, right now. And we've been working on this for about 2 years. And we started a managed alcohol program in one community, and now another community of ours actually is using Sublocade. But the systems are not ready to address the traumas of 150 years that manifest with the pressure of the pandemic, where people's needs to deal with their trauma require use of substances or alcohol. And we're not wanting to take a justice-based approach to it. We're wanting to take a harm reduction approach. And so that work, anti-racism and harm reduction, are 2 of the things that I mostly spend time on. I can't spend time on pediatric diabetes, which we started a long time ago, or any of the other things, because people are dying from colonization today. And I think I'll leave it at that. I think you get my gist over here. Thanks.
Great. Thanks so much, Barry.